Welcome to today's episode of HIPcast. Today, Seth and I have the privilege of bringing Katherine Lusk, who is one of the health information management leaders nationally in information exchange of healthcare data. So I'm very happy to get to introduce Katherine. I'm going to read her bio first, and then I'm going to give, surprise Katherine, I'm going to give just a little bit of personal experience information on you. Katherine Lusk is MHSM, RHIA, and a fellow of FAHIMA. She's the Vice President of Strategic Partnerships for the Texas Health Services Authority, with a focus on cross-industry facilitation of trusted data exchange that supports innovation and data mobility. She has long championed interoperability, serving in multiple roles, including Direct Trust Board, eHealth Exchange Work Group, the ONC Patient Identity Work Group, Epic's Care Everywhere Governing Council, the ONC AHIMA Project US Act Companion Guide, AHIMA Board, eHealth Advisory Committee, and the Texas Health Services Authority statewide multidisciplinary vendor agnostic interoperability collaborative. She's a strong believer in the power of informatics to bridge the healthcare delivery gap. So today, in case you can't tell, we're going to talk a lot about interoperability, some data exchanges, health information professionals in those roles, kind of what things are happening on the national landscape, what's happening in Texas, which is always leading, of course. But on a personal note, I've had the pleasure, Katherine also, yes, the AHIMA board, but Katherine is a past president of AHIMA. I also have had the privilege to serve with Katherine for almost 2 years now on the nominating committee. She and I were partners in interviewing in previous years for folks for the ballot for the AHIMA election, as well as the House of Delegates election. And so I've had great collaboration with Katherine over the past couple of years. So I have seen firsthand how well she can carry conversations and weigh in and still be collaborative, even if she's committed to one particular idea. She's definitely willing to go with the best solution decided by the group. So, Katherine, it's been a pleasure to get to know you at that level.
Well, it's been more of a pleasure for me. You are an exciting individual, Shannon,
thank you.
and you make the world shine every time you talk. So I'm excited to be with you here today.
Thank you. We're so happy you're here. We have, Seth and I both being kind of outside of a hospital or a provider setting for much of our career. We both spent a lot of time there in the beginning. And then we've kind of been out of that space for a long time. I know that you spent a significant amount of your career in the hospital provider setting, and now you are more in, you're definitely in the data interoperability scene, not only in Texas, but also nationally. You contribute consistently at every chance that you get, I think. So it'll be interesting to hear this conversation from the perspective of a health information professional that worked in that, the healthcare, the health system role for a long time. And then inspiringly, you made a transition to move into something new. And so for our health information professionals, it doesn't matter if you spend a long time in a healthcare system as an HIM professional, or 3 years or 1 year and move into something else. You have something significant to contribute to the health information space, patient advocacy, patient access to information, data exchange, all kinds of data governance, the whole shebang. So we're excited. Welcome, Katherine.
Yeah, and that makes me want to add a question that's not on our prep, but we always ask this question. I realize that it's not on our prep. So the first question is, what is the Texas Health Services Authority? But I'm going to ask a predecessor to that of, tell us about your HI journey that led you to Texas Health Services Authority.
Well, I wanted to, I'm not going to tell you my whole HI journey because that'll take forever. But I'll just tell you about working at Children's in Dallas. I worked at Children's in Dallas for a long time, for 18 years. And my title was Chief Health Information Management Exchange Officer. Because what I did was I was responsible for interoperability at Children's Health. People think interoperability is some scary sort of thing. It's really just release of information. That's all it really is. And our CIO was like, what? She understands that. She understands data. She understands consent. She understands privacy. We'll just give her that title and let her go. And so that was what I did. Is we were a large academic medical center that got referrals from all over the United States, and we needed that information to care for those children. So it was my job to figure out how to connect, how to make sure that information arrived and was there when our clinicians were taking care of children. What better mission? Who
Right.
wouldn't embrace that? Go figure. I was like, oh my God, I've died and gone to heaven. So, as an HIM professional, you can understand. I had grown up in the mail era, and faxing it was a miracle. So then it was just like interoperability. These children arrive in the middle of the night, and you mean we can get their medical history and make sure that they're cared for immediately, that they don't suffer? So I just set about doing that, figuring out about Epic. I volunteered to be on the Epic Care. I found out about Epic Care Everywhere Governing Council, and I said, well, I want to do that. They said, well, we think you should put in a thing. And so we'll see if we can get people to vote for you. So I did, and lo and behold, people wanted an HIM person.
Yeah.
So I got on the Care Everywhere Governing Council and started shaking things up a little bit there with standards and HIMA's patient naming framework and things like that. But just a great experience, learn more and more and more. And that's how I got started on this journey. I worked there, did all of that for Children's, volunteered to learn a little bit more every step of the way. And then when I decided that Children's was no longer the place for me, needed to do something a little bit different, I went to work for the Texas Health Services Authority, which is our state's health information exchange. So now what I did for Children's, I do for the entire state. So what I do is I work on how do I make sure that primary care physicians have the information they need? How do I make sure hospitals have that information? How do I shore up that electronic communication and make sure everyone can afford it and that the standards are there so the information can be ingested into the EHRs instead of relying on faxing? Faxing is better than the mail, but we really need to be able to ingest that information into our electronic health record so we get away from that double data entry. So much now is people are spent manually entering data that can electronically get there and it can be ingested up into the system if organizations follow standards and if they nudge their EHRs. So that's my journey. As I started out as an HIM person, interoperability is just release of information on steroids, and I embraced it.
I've never heard anybody explain that. I've never heard anybody explain it that way, that interoperability is just release of information on steroids. But that's a fantastic way to put it into an understandable process and concept, and one that I can probably spell better than interoperability, because I was thinking, how am I going to spell that when I post this? But
well, it's like my husband says, no one knows what the word means, honey. You just need to. And so it really it is release of information on steroids. And it's automating the process so that a person doesn't have to do it. And then people say, well, are you doing away with people's jobs? Absolutely not. Absolutely not. When we were doing these things at Children's, increasing interoperability and electronic exchange, my release of information people were working very, very closely with all the patients and families that called in helping them to adopt to patient portals, explaining what was going on, working with the different EHR vendors. So no, it heightened their skill set. It made them get to do things that were more fun. I mean, what's fun about picking out pieces of the history and physical discharge summary consult? I mean, how fun is that? But working with patients and families on connecting connecting and getting their information electronically, understanding that they can schedule their own appointments online, that's major fun. Helping them to get disability determination in 1 day instead of 2 weeks, making sure their financial burdens are decreased. That is fun and rewarding. So when people are worried about that, not to worry. There's lots of more fun things for you to do.
So many more. Thank you for that.
I know.
Yes.
Yeah.
So that's how I got started, Seth, and that's how I just thought, well, if anyone's going to drive, I'm going to drive.
I love it.
Because I will know how to drive to make sure the content is there, that we follow standards, and that we meet regulatory compliance. Because I personally, through my credentials, knew more about those functions and those service lines than anyone else.
Yeah, absolutely. Tell us, give us the elevator pitch for what is the Texas Health Services Authority.
Oh, I've got that down.
I figured.
The Texas Health Services Authority was created in 2007 as a public-private partnership with the state of Texas. We have a 12-member board of directors appointed by the governor, confirmed by the Senate for every 2 years. We meet with our board of governors on a quarterly basis, and they manage us. Our board of governors includes people from all over the state of Texas and every single discipline.
That's awesome.
Yeah.
And you exist to make data portable, health data portable.
We exist to make health data portable, to make sure that the cost of healthcare in Texas goes down, that clinicians have the information they need when and where they need it, and to establish standards so that this information is easily portable and scalable.
That's awesome. That's awesome. So thank you for that. Let's talk a little bit about the Interoperability Collaborative. What is that? Who participates? What kind of projects do you do?
Oh, that's my most fun thing that I do, Shannon. You already knew that.
I knew.
You knew. What the Interoperability Collaborative is we bring together all the stakeholders across the state of Texas. And you don't have to live in Texas. We have people from California who participate because they've got a Texas connection. And we work on how do we break down those barriers? What's causing there to be wrinkles, barriers, slowness to adopt and things like that? So we have vendors, we have CIOs, we have physicians, we have nurses, we have informatics people, we have HIM people, we have IT people, and we have everyone, home health people, disability, everyone who's involved in healthcare in the state of Texas is invited. And you know what? They show up and participate.
That's awesome.
And we work on what can we do to improve the interoperability? How can we make sure that information travels with us? So I'll just tell you about our different work groups and the things that we've been doing. We have a standardizing CCDA work group. And HIM people think, well, I don't know what a CCDA is, but you do. All the CCDA is, all those different components in a discharge summary, a history and physical, a consult, that we break it down into, like a diagnosis, procedures. CCDAs are just electronic ways of sending that information. So when you send that information that you compile in a doctor's office or home health, you need to break it down into different buckets so the information can go electronically in a consistent way. So the information can be ingested into the EHR. For example, should you have to manually enter allergies every time? Maybe not. Maybe you can get those allergies from someone else and just verify them with the patient. It's a lot easier to edit than it is to create. So that's what a CCDA does. Well, I have the primary care physicians in the state of Texas said, wait a minute, this is not working well for us. EHRs were supposed to make things better, and they're not. We're ticked off or angry. Things have got to get better. So it's your job, Katherine, to make it better. So I said, okay, we can do this. You can't be defeated. You can do this. So we did do it. We figured out, well, what needs to go into a discharge summary CCDA and what are they getting now? So they were getting everything, like thousands of pages, or they were getting nothing. So we figured out, well, what do you need to get and what are the CCDA components? They came up with a list. We vetted it across the state of Texas. We had a student from University of Houston send out a survey to the physicians in Texas. We refined it. Then we worked with HL7 Structured Documents Group to get it refined even more. And so that it could be included with the for a certified EHR. So we came up with a standardized discharge summary, CCDA. We vetted it across the community, and we got our communities to adopt it. And then we got the different EHR vendors to adopt it, because I then sent them all a notice and said, hey, we're doing this in Texas. And this is what we want you to do. And then each one of our stakeholders who use and buy and purchase their EHR product then sent them a notice. So they're getting all kinds of encouragement to adopt a discharge summary CCDA. We then sent it to the Sequoia Project Data Usability Work Group, and it's a part of their December 2022 implementation guide.
That's big work.
Well, and I'm going to tell y'all something even better than that we recently did. And one of the HIM students from Indiana University, who lives in Texas but goes to school virtually in Indiana, we worked on a maternal health CCDA.
Nice.
Yeah. So we worked with a federally qualified health center and a hospital in Texas. Health Services of North Texas, federally qualified center. Texas Health Resources is where they deliver babies. We found that they were having to fax those prenatal records in when people went into delivery. So what happens if you go into delivery in the middle of the night?
Yeah.
What happens to your wife, Seth? She's standing there saying, wait a minute, I need you to give me some medication. And they're saying, wait a minute, I got to get somebody to answer the phone. I got to get somebody to fax that record. I got to get, care was delayed. And so we worked on how can we improve that? So we worked with the OB/GYN and said, what do you need? We had an HIM student, Michaela Harrell, just a joy. Michaela Harrell sat and looked to see, okay, what is required on an antepartum record? What is required on a labor and delivery record? What can we electronically send so that information doesn't have to be manually entered? Who knew that more than an HIM person? No one. So Michaela did that for us, and we got some other students to do some other things. And we presented to the HL7 Structured Documents Group for an antepartum summary progress note document with minimal clinical content. And you know what? They loved it.
I'm sure.
The HL7 developers said, we need people to come and talk to us about what is clinically relevant. What is a regulatory requirement? Because we're developers. We know how to technically make it happen, but we need people like you to tell us those other pieces. A great partnership. So we've begun that journey now. I've got another hospital that's going to join in there, and they're a Cerner shop. So Cerner doesn't know it yet, but we're going to be knocking on their door.
I love
Surprise.
I'm curious to know, Katherine, How did you, so, a lot of times when we do projects in healthcare, and probably every industry, but in healthcare, there are just so many barriers to get a project going and to get adoption of this. How did you go about identifying that that's where the biggest need was and then get the
The
adoption?
stakeholders, yeah. Well, the stakeholders tell us, Shannon.
Okay.
We've had all these stakeholders. Like I said, the primary care physicians told us the discharge summary CCDA was an issue. The federally qualified health center, that's a member of our work group, said maternal health is an issue. And so stakeholders say this is what we want to work on.
Okay.
We also have a group that works on increasing adoption of direct secure messaging. Doctors' offices and hospitals need to be able to send messages to one another. National networks like Care Equality, eHealth Exchange, and Commonwealth are beautiful, but they're kind of like repositories where you have to know to pull the information. Well, a lot of times you need to be able to send information. So how do you send that information? You don't want to pay for an interface to each and every hospital in Texas. There's like 600 hospitals. You don't want to do that. And I don't know how many doctors' offices there are, but they don't want to pay for an interface. So how do you do that in a cost-effective manner? Well, you use direct secure messaging. And every certified EHR in the United States has to have direct secure messaging. So we have a work group that works on how do we make sure everyone has a direct address, knows how to keep their directories clean and tidy, and knows how to send messages to one another.
Katherine, that kind of brings me, I know you and I had the opportunity to share with some students recently. I came on right behind you, but I came in and listened to as much as your presentation as I could get to that day. And you were talking about something related to this that I thought was incredibly cool. The messaging from please tell us about that project.
That
Really,
is a
it's
major
fascinating.
Cool. It is a major cool project. One of our critical care providers in Dell Children's, Dr. Michael Oth, said, we need to do something to allow us to instant message with people. Children show up in the critical care unit at Dell Children's, and I need to get in touch with their PCP to find out what's going on with them, or their community cardiologist. And unless I happen to go to school with them or know them personally and have their phone number, I'm dialing their answering service, and who's then calling somebody, who's then calling somebody else, and there's delays. There has to be a better way, because in those emergent situations, I can't send a direct message because a direct message is not meant for that purpose.
Right.
It's more of a business purpose that you follow up on. We needed an instant messaging platform. Well, you can instant message within an organization and get somebody from housekeeping to come, the police to come, or something like that, or security. But he could not instant message with the community providers. Mm-hmm. So we met with Direct Trust. And as Shannan said, I'm on the Direct Trust board. And that's why I got on that board, Shannan, because I knew they needed HIM people.
Yes, yes. Aren't you the chair of that board this year?
I am now the chair.
That's right.
Yeah. They voted me in as the chair after I was so enthusiastic. After a year, they said, well, you should just be chair. And I said, well, wait a minute, I don't know. They said, yeah, you should be. And I've enjoyed it. I mean, and I believe I'm making a difference. So we have a project with Ascension Health and Dr. Michael Off working with Direct Trust on setting up instant messaging so that the clinicians within Ascension Dell's Children's can reach out to community providers on the different platforms, because Ascension uses Volt internally and Athena uses Athena Text. Well, there is a standard through Direct Trust, 10 plus, texting instant messaging plus, or something like that. I can't remember what it means exactly. TIM plus, where that they use this standard. Both of these instant messaging platforms can communicate with each other across platforms.
That's real time and meaningful.
Yeah,
and it's very meaningful.
Oh, it
Mm-hmm.
is huge. And we've had one implementation-a-thon where we show that it really can happen, that it's really true. And so now we're working with vendor partners to adopt this standard and to make it happen. And so we're really, really excited about it. And we think that it's going to make a huge difference in clinical care and also with the payer community because they want to be able to authorize things quicker.
Oh, that'd
So
be
how do
great.
we authorize things quicker? How do we make sure that things are not and they don't necessarily need to be in part of the legal medical record. They just need to be able to be there from a business standpoint. So how do we make that happen? So yeah, that's our 10 plus
So good.
project.
Yeah, that's a
It's
great
like major
project.
cool.
Yeah.
Mhm.
Well, and I was also curious on you mentioned the discharge summary and a CCDA, and then you went into some maternal health. But I know you've been working on progress notes, an antepartum summary progress note document. How's that project going? And tell us about the journey for that project.
Oh, that one's going really, really well too, Seth. That is the one where recently Ascension is asking to find out more about that. We're working with Health Services of North Texas, which is an ECW client, and we're working with THR. And now Ascension wants to find out more about it, so we'll begin working with them. So we will begin vetting the clinical content and the antepartum summary progress note across the state of Texas and to get our Texas participants to adopt the note and begin sharing that way. So that's where we are right now. We've sent the note at the HL7 structured documents. We were able to send it through direct secure messaging. And so now the next step in our next test is being able to query for it, which I don't think it'll be an issue at all.
That's
Yeah, that'll be
awesome.
very meaningful.
Yeah, does it feed into your other maternal health project? I imagine that it does. It's got to be at
Oh
least
yeah,
connected.
yeah, it does. It creates trusted information.
Yeah,
Trusted information following standards, and so clinicians do not have to manually enter that data.
so good.
So it eliminates phone calls and everything, and we're really, really excited. It feeds into the 21st Century Cures Act, and in fact, we commented on USCDI 0, which has a maternal health, saying that they should adopt our standard. Go figure that we would do that.
Uh-huh.
And we also commented on USCDI plus on the same thing, that they should adopt our standard. So we provided an input to Sequoia Project Data Usability that they should include as part of our implementation guide the antepartum summary progress note document.
That's awesome. And I'm sure that you all, unrelated to, not necessarily related to the maternal health, but I'm sure that you're constantly having conversations about TEFCA and HTI 1 and 2. Give us an update on kind of where those things are. What's that impact been to Texas?
Well, actually, Texas has a like 80% of our 81% of our hospitals are connected to national networks.
Okay.
So like 40% of our beds are Epic, and so they're part of the Epic QHIN, and the other hospitals are part of major networks like Commonwealth, and so they're connected to those QHINs. Now, our ambulatory organizations, No2 is a big force in their QHIN, and so we're just kind of monitoring it, watching how people are doing, and figuring it out as we go along. Right now, Shannon, I don't know that TEFCA is going to make much difference in the hospital exchange. Where it'll really make a big difference is with public health and with the payer community. The big change with TEFCA, I think, is the national networks and direct trust. Actually, we do lots of messaging for clinical care, for treatments. It's a safe place. And people are very concerned about HIPAA compliance.
Mm-hmm.
And so public health and the payer community, even though it's allowed via HIPAA, has not really been an accepted process because people are so concerned and wanting to be protecting a people's privacy. but with the right controls, it can happen. So what TEFCA will do is it'll free up the payers to take advantage of things and to streamline their business processes and hopefully to cut our costs. And it will free up public health to get that information more timely, because public health right now, in order to find that information, has a lot of manual efforts. So if they can look on the national network and gather that information and streamline that, maybe they can, if another pandemic happens, which we know it will, they'll be able to get ahead of it faster. You know, with COVID, we were struggling to get ahead of it initially, weren't we?
Sure.
We have to admit that.
Yeah, sure.
But with TEFCA and freeing up that sharing of information a bit, our public health partners can get ahead of things. And so that's where we really think, or I really think, that TEFCA will benefit the state of Texas.
Yeah, that's awesome. So you talked a lot about some of the QHINs and national networks. So it sounds like you had a pretty mature, and I know this to be true of Texas, you had a pretty mature footprint of exchange already, at least in the Triangle. I don't know if that's actually statewide or not, but I'm curious then for the designation of the QHINs, you know, that initial 5, and then I think we've had a couple of more since then. We maybe have 7 or 8 now, at least 7, maybe more. That really, the designation of those hasn't really had a direct impact on the information exchange in Texas because you were pretty mature already, I would think. Is that true?
That is true. I do think that it will have a bigger impact with public health and the payers. We don't have, while we do have payers that participate in the collaborative, and we work on how can we improve interoperability. I'll tell you a cool project that we're doing with a managed Medicaid organization. We're working with the Texas Homeless Network and Superior managed Medicaid. And Superior really wants to make sure that when patients are discharged from the hospital, they go home to a safe environment. And they don't know when their clients are having housing insecurities or seeking the services of the Texas Homeless Network. So we connected both of them, and we served as a convener to help them figure out how to share information and support their community. And you know, a lot more people than I had initially envisioned have Medicaid benefits that are seeking services from the Texas Homeless Network. So we were able to get the Superior to share information with the Texas Homeless Network on who does have services available, and then those case managers are able to help people get their medications filled, get primary care physicians, because the Texas Homeless Network, they want people to get the services they need. And as they work to get people sheltered, they work to make sure that they go to their doctor's offices, they get their medications. So knowing people have benefits was key. So that's another project that, once again, that people stakeholders identified a need with the homeless population. And then we connected with Superior, said, how can we make this better? Now, we are still continuing on that project. How do we expand it further to get more of the Medicaid managed care organizations? So the Texas Homeless Network is working through their governing board, because this is all new to them. You know, to me, it's really, to me, it's like, okay, we got to get this ball rolling. We can help you. But to them, they have to sit back and thoughtfully think about it. And how do they protect the privacy of people?
Yeah.
And now Superior to them, they're ahead of the Texas Homeless Network, because they can had a V8. I can see the value. I can help these people if I mean, those nurses was inspiring to me, to have those nurses tell me, oh my goodness, we didn't know. And if you'll give me the name of the shelter that they're seeking services, we'll call right now. We'll get in touch with people. We'll work things out. But just connecting people that way.
Yeah,
So
That's awesome, Catherine. I'm curious on the homeless network and the Superior. Is that a 2024? Is that happened in the calendar year of 2024, or is it a little older? I'm curious about data.
No,
Have
we've
there
been
been any
doing it.
outcomes change?
No,
Yeah,
we
haven't
haven't.
data yet. Okay.
Yeah, no. And in the odd thing about THSA was we are governed by statute.
Hmm.
Wow.
Statute does not allow us to analyze
Yeah.
data.
Wow.
Gotcha.
So I can, I could analyze data if it's not my data. I can't aggregate.
Yeah.
I can't aggregate and analyze data, but I can analyze data that's not my data, and I can aggregate data. But anyway, we are governed by state statute.
Okay, so some limitations there. Superior would probably need to be the actor there to put that data together and share it out.
Yeah, yeah. And Superior is looking into how can they measure the success, and they're great partners.
Do you have a favorite project that you've worked on with everything that you've done over your career? I mean, it's so cool to hear. Do you have a favorite? It's like choosing a favorite child, right?
Oh no, Seth. I mean,
every once in a while, I think I could choose a favorite child. I don't know, but
I'm not telling Kristen, and I'm telling the girls never to watch.
No, we're going to tell them never to watch too. No, I honestly, no. I mean, one of my favorite projects right now is, of course, that antepartum summary progress note. But another one that I have that's like major cool is birth defects and electronic case reporting. We have a work group, the newborn work group, newborn screening and reporting and documentation. So you can imagine those are pediatricians. Mm-hmm. And there are children that are born with critical congenital heart defects. And it's required in the state of Texas that you report. But there is no penalty for not reporting.
Oh, wow. So there's a registry that's...
Yeah, there's a registry.
Wow, okay.
But, however, there's not much publication that there is a registry. Mm. And so it's in statute, but it's kind of hidden. And so because pediatricians graduate from school and they never know that they're supposed to report, so the reporting is low. So this work in the state of Texas offers services for these children, and they help these families. So we worked with this work group. I'm just really proud of this work group. And Dr. Joe Schneider leads this work group. He's one of my faves. And so we work. I have lots of favorites, as you can see. Dr. Nike
probably aren't going to listen. It's health information professionals. You're safe.
I know. Well, they might. Who knows?
They might.
And we worked with the CDC and our Texas Birth Defects Registry to get those critical congenital heart defect diagnosis codes captured and automatically generate a notice to public health through ECR. Because, HIM professionals are all over coding those things.
Yeah.
Mm-hmm.
So an HIM professional codes that record, and they do. Our profession is great about that. And because of that, those children in Texas are now getting the services that they need immediately after birth. Because the baby is born, the HIM professional codes them, it submits it, it automatically gets to generate something to birth defects, and they are on it, contacting those parents and families to get those children those services they need. So, Seth, that's one of my favorites right now.
That's wonderful.
And you have to, and once again, stakeholders identified. The pediatrician said and the birth defects registry said, we just know that we must have more heart defect issues in Texas than they're getting reported. Yeah. And once again, Shannan, I can't measure it, but
well, you could probably find out the number that's reported new every year in the newborns. That's probably something that the registry would
do. Yeah,
they may even have it, right? You can't report it, but I bet the state has it. So Katherine, this has been so fun as always, so informative, and your passion is definitely shining through in both health information exchange and making an impact in health outcomes through that health information exchange, which is incredible. Thank you for joining us today. Thanks for coming on and talking with a couple of old Tennessee friends.
That's right.
Well, thank you for having me. And I'm hoping that more HIM people apply and go to work for health information exchanges and
Absolutely.
vendors and share your knowledge.
Yes.
They need you.
Yeah, watch
That's
for
right.
for the health information professionals listening, watch for the HIEs and the QHINs as they ramp up and start onboarding providers. You're a perfect fit for onboarding providers and helping define standards for particular the use cases that Katherine shared today. Those are you could do that for from now until eternity and not
You
have all the
could.
forms completed, right? So plenty of opportunity.
That's right.
That's
Well,
what.
thank you again, Katherine. It's been a wonderful conversation. And Shannon, until next time, my friend.
See you next time, buddy.